it always requires a special moment for a special appearance. Be it offline or online, the courses of AMNMT have always been the trendsetters. They are known to be the futuristic courses because most of the topics or the content what we teach is not currently in practice, but they can be used clinically because of their sound fundamental background in terms of be it the pathomechanics or be it the functional recovery. We are coming up with the course of all the courses, the ARTHROMANUAL therapy, AMNMT, at our very own capital of our country, at New Delhi, on 16th and 17th December 2022. It's a certified AMNMT practitioner course, which is must for every clinician who seriously wants to know the best of manual therapy within the domain of physical therapy. Especially before learning other adjunctive techniques and upgrading your skills, it's important to understand the multistructural paradigm of arthro-myo-neuro, the articular, myofascial and the neural. Integrated technique. In one technique itself we can target all the three structures. The same way how every functional activity requires all the three impairments or dysfunctions getting their clinical presentations, articular, myofascial and neural. So today I have come here just to see that I introduce the one dimension of the 3D aspects of AMNMT, that is the articular or the arthro-manual therapy. We are familiar with articular techniques. For example, I have the lower limb skeleton with me with the patella, the fibula, tibia and of course the ankle and the foot. I am giving you an example here. We are aware of the first and the foremost what we usually see when the subject tells difficulty in walking, difficulty in stair climbing, difficulty in prolonged standing, difficulty in squatting or difficulty in sit to stand in the knee. And they say that it is associated with stiffness of the knee. They are not able to either straighten or they are not able to fully bend the knee. And then you see for the Enfield and you find that it's not the muscles shortening that is restricting the range of motion. Because you give hold relax, it does not improve the range. And it is not the spasm because it's not associated with pain. The range of motion restriction is a tissue stretch. After the stretch is the pain. It's not like when you take it itself pain and you stop it. Okay, so it's not an empty Enfield. And then finally you are narrowing it down to the articular structures. The articular structures can be the intra-articular, which is the synovial fluid and the articular cartilage, whereas the periarticular, which is with the capsule and the structures that are blended with the capsule. For example, here the retinaculum of the patella, which is actually blended with the knee joint capsule. The pes anserine tendon, which is medially there, or laterally be it the iliotibial band. So understand that the anatomical picture will give you the clue which structures can be pathomechanically influencing each other. So now I come to that point whether it is articular, so I want to treat this joint. So what options do I have? I observe the patient's knee. Patient is in supine lying. Okay, so I observe the knee and I find that the tibial tubercle is more lateral. And the subject is having a genu varum, which is characteristic of the tibiofemoral osteoarthritis knee. So static out of position, the tibial tubercle is lateral with respect to the patella or with the femur, and it is not a rotation problem of the tibia because I can know that from the malleoli, the medial and the lateral malleoli, okay, how it is anterior and posterior compared to the opposite side. So the malleoli are symmetrical, but only the tibial tubercle is lateral. So I know that it is laterally glided tibia dysfunction, static dysfunction. So this indicates us to give a medial glide as an oscillatory mobilization depending upon the grades of mobilization of Jeffrey-Maitland, because it's a static dysfunction. So I correct the therapeutically medial glide mobilization technique of Jeffrey-Maitland. Yes, that's only the first part of the story. You might correct it, but you see that the flexion range is not improving, or the extension difficulty which was there in the patient is not improving. Then you identify that it is a capsule tightness, a posterior capsule tightness, which is limiting the extension range. And we might advise the subject on lying down prone and putting a sandbag here to give a sustained stretch to the knee, so that the extension, because capsules require more longer stretch. Remember, to stretch a muscle, you have to keep that sustained for 30 seconds. If you are going to elongate the fascia, which is related to the capsule, definitely you have to hold the stretch minimum for 3 minutes. That's why many of the times we give that skin traction or the other aspects which will be more sustained, so that the 3 weeks period it's given for the capsules to get lengthened and adapted to the lengthened position. Okay, so we just maintain the stretch, and then we also ask the subject to rest the heel on a surface, okay, on the surface, and push the knee down, which is nothing but the Mackenzie's concept, the mechanical diagnosis and therapy. So you have a movement restriction, which is a dysfunction syndrome, and you are correcting it, either active or self-assisted or passive forces to improve the extension. It's not a sustained extension manual stretch. You support it and giving the pressure on the anterior aspect of the knee. You would have seen the literature on Robin Mackenzie's mechanical diagnosis and therapy for the peripheral joints, where you will see such kind of examples. That is also an articular option, because we treat the capsule specifically. You can't treat a posterior capsule tightness with a posterior glide or anterior glide, because this is oscillatory. Oscillatory technique will not be effective. We need sustained stretch. And in the sustained one, Mackenzie is always the best because we have positions which we can just maintain. And it's a self-treatment patient can do at home. So Mackenzie comes as the second option for the capsule. Whereas for synovial fluid mobility, rehydration, oscillatory mobilization will help. Articular cartilage regeneration also, oscillatory mobilizations will help, because that is the property of those tissues. So if it is laterally glided, I find that I give the Maitland's medial glide. I find the posterior capsule tightness, then I give a sustained extension, which is the Mackenzie's mechanical diagnosis and therapy. And then subject tells on stair climbing, I have the knee pain. So that means keeping the leg and coming up, the stair climbing, having the symptoms. So that means it's a functional symptom. I see that tibial tubercle I have already corrected with the Maitland medial glide. I rectified the posterior capsule tightness with the Mackenzie's concept. Whereas this functional one requires a functional technique. That means subject keeps the foot, I give the medial glide, maintain the medial glide, and the subject comes up. Maintain the medial glide and the subject comes up. Okay, maintain the medial glide. When the functional activity is happening, I maintain the medial glide. So that is the mobilization with movement. Because functionally, physiological movement and accessory movements both are happening simultaneously. So that is why Brian Mulligan developed his concept, the Mulligan's concept of mobilization incorporated together with the movements. Subjects have immediate drastic relief and great improvement in the functional performance. They are very happy. You have treated the intra-articular component with the Maitland concept. You have treated the peri-articular concept, the techniques with the Mackenzie's concept, and then the functional impairment with the Mulligan's concept. is it the end of the story? Remember the case when I told in the beginning, the patient has restriction of knee flexion also. And then I observe the knee flexion, how it is happening. And I find that the tibia is going laterally during the knee flexion. Immediately, as a movement scientist, every physical therapist will be alerted that why is it externally rotating during the flexion? Because if you do internal rotation, more flexion will come, full range. Okay? If you do an external rotation, it is a locking position. So the subject is having an external rotation during the knee flexion, which is the cause for the restriction of the range of motion. Or is it the patellar inferior glide that is restricted? That restricts the knee flexion. So multiple aspects can restrict the knee flexion, articular itself.